He is a tenured professor in Indiana University School of Medicine at Indianapolis. He is internationally recognized both clinical and translational research point of view in nephrology. His main work is, initial and lot of work has been done in hypertension in dialysis, not only in terms of a definition, but also target and the line of treatment. He has published more than 400 review paper in very high impact journal, and he has been chair of education committee of many randomized control trials to name few: Credence, Sonar, Figaro, and Fidelio. He has got many awards to his credit, and again to name just few: Indiana University Trustee Teaching Award, Young Scholar Award of the American Society of Hypertension, and Clinical Excellence Award from NIO. NIO is American Nephrologists Association of Indian origin. So with this word, what the program is that I will have a brief background for 10 minutes or so, and then we'll hand over to Rajiv for taking you through the management, broadly management of diabetic kidney disease, and specifically more on role of Finerenone in diabetic kidney disease. So what I will do in the next 10 minutes or so to take you some basics, broad area how the patient of diabetic kidney disease should be managed or is being managed. So we know that India is Southeast Asia has got a very high burden, and this cartoon comparing burden of diabetes in 2015 against 2040, and in 2040 South Asia will be having approximately 140 million diabetes, and in outer South Asia India is one of the labeled as diabetic capital of the world. So we have got huge burden of diabetes. Now this cartoon shows, this is unpublished data from Global Burden of Disease India chapter, and what is it is comparing the prevalence of diabetes between two time frame from 1990 to 2016, and it's comparing between male and female, and the basic message out of this cartoon is that as the age progresses, prevalence of diabetes is higher. Prevalence of diabetes is higher in male as compared to female, and if you compare the two time frame of 1990 and 2016, there is a significant increase in burden of diabetes in our country. Once you will see the etiology pattern of end stage kidney disease, so major increase of magnitude of end stage renal disease is because of the diabetic kidney disease, whether we take it in terms of a rate or in terms of a absolute number. In spite of so many years has gone in mortality as compared to person who doesn't have any of these two diseases. And what this cardiovascular mortality is in every aspect, every clinical pattern of cardiovascular mortality, whether it is congestive heart failure, acute MI, CVA, peripheral vascular disease, every part is every clinical pattern is affected by the presence of chronic kidney disease on the background of diabetes mellitus. And this is a important slide comparing that if we take 100 patients today of chronic kidney disease, then majority of them actually do not reach to end stage requiring renal replacement therapy, rather they succumb because of a cardiovascular complication. So which means that while managing patient of diabetic kidney disease, in addition to retarding progression of kidney disease, any treatment which helps in retarding the cardiovascular complication will be a very important component of management of these diseases. Now, in terms of a driver of or the factors which causes progression of diabetic kidney disease, there are three broad factors. One is glycemic control, other is intraglmerular hypertension and systemic hypertension, and third is inflammation and fibrosis. So these three in every patient contribute with some variable degree out of these three components. So what we know that a good glycemic control is one of the predominant factor in initiation of diabetic kidney disease as well as progression. And this slide shows that if the hemoglobin A1C goes beyond target value of 6.5 and 7, the incidence of a kidney involvement is significantly increased. And we are aware that even in late last few years also, the target hemoglobin A1C is only obtained in somewhere 60 to 70%. A large number of 30 to 40% is still, in spite of having so many anti-diabetic, are not maintaining the hemoglobin A1C target within the recommended value. And whatever drug we use, as we know that the cardiovascular complication is an important complication while in a course of patient or diabetic kidney disease. So we need to decide that those anti-diabetic which has got a protective cardiovascular component will be definitely having much more role. And out of these two, GLP-1 agonist and SGLT2 inhibitor, SGLT2 inhibitor in addition to diabetic control has got a very significant protective role in terms of a cardiovascular complication. Now we know that the drugs for last so many years are acting on those three primary pathogenesis: good glycemic control, intraglomerular hypertension, and systemic hypertension. And it's only lately that the inflammation and fibrosis and the drugs decreasing this role has come into picture. So this slide shows that the role of ACE inhibitor, a good glucose control and hypertension control, retard the progression of disease. Now these are the two early landmark trials, RENAL and IDNT, which shows that the ACE ARB has got significant protection and decreases the development of a diabetic kidney disease and its progression as compared to placebo and other antihypertensive. But still, if you see the cartoon, there is a residual risk still persists if somebody is being managed only on ACE inhibitor or receptor blocker. Now, in spite of knowing that ACE inhibitor and receptor blocker are the key standard of care in a diabetic nephropathy from the early stage to late stage, still this slide shows that if we take a population, not more than 50% patients are on ACE inhibitor and receptor blocker, in spite of these drugs being available for so many years. So this slide shows the use of SGLT2 inhibitors. So if on top of ACE inhibitor and receptor blocker, and whatever additional residual risks was there only with use of ACE inhibitor, there is an additional benefit of SGLT2 inhibitor. But in spite of use of ACE inhibitor and SGLT2, still there is a residual risk on which some other drug can be used to further improve the outcome of these patients. So this is a long history from early period to this, and only summarizing that initially ACE inhibitor and the receptor blocker were useful in decreasing the development of a diabetic kidney disease and retarding progression. Then SGLT2 inhibitor came into picture, and now practically, although not in the guidelines but and standard of care, but probably majority of nephrologists will be using ACE inhibitor and SGLT2 inhibitor in majority of patients of diabetic kidney disease. So if we come to what is unmet need, although these newer drugs are available, but still probably prevention of low birth weight, which has got impact on low nephron number and future diabetes as well as hypertension and chronic kidney disease in adult, is still one of the important as far as India is concerned, because at least 30% of childbirths are low birth weight baby. In addition to that, we need to decrease the development of diabetes by a very good lifestyle modification, and then a early screening, and then a good glycemic control, as well as a maximum use of ACE inhibitor and the SGLT2 inhibitor. But in spite of all these armamentarium available with us, still there is a significant role of mineralocorticoid receptor blocker, which is the area which Dr. Rajiv has got a huge number of study and the data. And with this, I will end my presentation and invite Rajiv to take further on diabetic kidney disease and much more on a newer drug subject.
Thank you, Dr. Agarwal, for that very kind introduction. I'm coming here after 35 years or so to speak at All India Institute. I started here in 1981. And I'm going to tell you a little bit about what Dr. Agarwal already said about type 2 diabetes and chronic kidney disease. Here are my disclosures. Now, to sort of broadly speaking, when I joined the Institute, there were things that are written like right here. You'll never remember what is written there in Sanskrit. And one of the things that you will read, it says Tamso Ma Jyotirgamaya, right? And what it means is, from darkness take us to light. And it says, well, what does it really mean? As if you are an All India Institute, it's telling you that if you are not having the knowledge, then gain that knowledge, because that will dispel the darkness of ignorance. And that is the way that you can help people. And the second motto that used to be there, which I remember, was Sarve Santu Niramaya. That was the motto that was there. And what does it mean? It says that may all be healthful, may all be healthy. Sabhi Sant, without disease. So, but it was not absence of disease, but health. So how do we combine these two? Where you dispel ignorance, but then you adopt a way that can improve the lifestyle of the people that we are here to serve. So I'm going to divide my talk in two parts. First, to tell you what I have learned on how we can do in very simple terms. And, a lot of people who might be listening to this across the country, they might not be nephrologists, but I will try to tell you what it means to look for kidney disease. And the first thing we do for kidney disease is that, we look at creatinine and we call something EGFR. And if you're just doing that, you're sort of missing half the story. Why? Because you're not measuring injury. If you are a cardiologist, you're going to measure troponins, but you're also going to go and do an echocardiogram or BNP, right? One is looking at injury, where the heart is getting damaged, releasing enzymes. The other is looking at loss of function, which is low EF. Why in nephrology we just look at loss of function, which is EF equivalent, not injury, which is proteinuria or albuminuria? If you're not screening for albuminuria, you're missing the boat, because you're waiting for failure to happen and you're trying to repair that. So think, when you see a patient with type 2 diabetes, do you have injury and do you have failure? It's a very simple test. Now people might say, it's a very expensive test, not everybody can afford it. Can you do a dipstick? It costs 100 rupees. You can do a dipstick, and if you have proteinuria, you have injury. You don't need to do anything fancy. You got 2 plus proteinuria, 1 plus proteinuria, you're in trouble. You need to raise the 911 alarm, because what we have learned is that if you combine the two, you would get a better sense of risk stratification. And here's the diagram that shows that. On the top, you can see albuminuria, less than 30, 30 to 300, more than 300. Those are the threshold. Less than 30, no albuminuria. Very good. 30 to 300, what we used to call microalbuminuria. More than 300, macroalbuminuria. And look at the vertical part, and shows you the GFRs. Just focus on where the arrow is, 45 to 59 GFR. If you say, oh, you got some failure, but if you have failure and a lot of protein, you're in the red zone. If you got very little protein, you're in the yellow zone. What it's telling you is stratifying the risk. And what is it stratifying the risk for? It's telling you that the risk of cardiovascular death is increasing. The risk of cardiovascular death is also increasing by increasing UACR. So both ways, you're going up. But not just of cardiovascular death. Dr. Agarwal pointed out, more people will die from kidney failure than reach dialysis. So the people who get on dialysis, they are your success stories. They are the people who survived their heart attacks and the strokes, and those are the people who reach there. But low GFR and albuminuria both predict all-cause mortality, cardiovascular mortality, heart failure, end-stage kidney disease, and even acute kidney injury. Somebody has albuminuria, that patient is at a heightened risk of acute kidney injury if they go through a contrast procedure or they come in the hospital with sepsis, whatever. Now, how useful is albuminuria in assessing cardiovascular risk in people with diabetes? Now, this story is not very old. It's actually dates back only 1984. And this is Dr. Carl Eric Mogensen. I met him when I was a fellow. He was visiting us. And he had a single author paper in New England Journal of Medicine. Single author paper. And what did he do? Just measured albumin in 232 people with type 2 diabetes and followed them for all-cause mortality. And what did they find? Well, if more the albuminuria, the more the risk of mortality is what they found. Why did it get in New England Journal? Because he had a brand new assay, radioimmunoassay, and somebody had just won a Nobel Prize. Dr. Kochupille trained with that lady, actually, who won the Nobel Prize. Dr. Kochupille was in endocrinology here. And she had won the Nobel Prize for discovering the radioimmunoassay. And what he showed was that a simple tool of getting albuminuria will tell you the risk of heart failure, of all-cause mortality. Now, there was a study done late 1990s. It was called the HOPE trial. And the HOPE trial was really remarkable because it was a factorial design. It was testing vitamin E and ramipril in people with type 2 diabetes and see if it could reduce the endpoint of cardiovascular death, myocardial infarction, and stroke. And in this study, they asked whether albuminuria could predict all these outcomes. And they looked at the baseline UACR, so just measure the urine albumin to creatinine ratio at baseline and look at all these outcomes. And what did they find? It tells you the risk of CV death, MI, stroke in 12.7%. It explains that much. All-cause death by about 17%, and heart failure about a third of all the risk in people with diabetes can be explained by something which is not ejection fraction or or anything. It was just a simple UACR testing. Really an important definition for cardiologists. What is more remarkable is that the risk starts rising even at levels of albumin we think is normal. 30 milligram per gram is the threshold that we take, above which we say microalbuminuria. And the risk you can see on this slide has already started rising even below 30. So it's a continuous risk factor. Now, how are we doing globally? Terrible. You can see In France, only 29% of the people have global USCR screening. In the Netherlands, 57%. And 1 out of 3 in United Kingdom don't have this test, even though every year ADA has said that we should get a USCR testing annually in all these people. We're not doing very well. How about in United States? Well, it's a very heterogeneous country, but if you look at the distribution, it says GFR testing almost everybody gets, which is in the C figure. And in the D figure, you can see it varies anywhere from 13% to 75%. Median, about half the hospitals are getting USCR testing at least once a year. So many hospitals are not even doing it. 10% of the hospitals, very, very low amount of testing. So it's a problem not just in India, but it's a global problem that people are not recognizing that urine albumin to creatinine ratio testing is an important parameter to diagnose kidney disease. And you can see that in the USCR testing, very few people are getting tested. Now, why is it important? Well, one of the things that we know is that as kidney disease advances beyond stage 3A, so you're looking at people with 45 or lower eGFR, the atherosclerotic cardiovascular disease or ischemic strokes or peripheral arterial disease tend to plateau. But that's not true for many of the other non-atherosclerotic cardiovascular events, such as sudden cardiac death or arrhythmias or hemorrhagic stroke. And why is it important for your patient? Because the first event is more likely to be fatal in a person who has chronic kidney disease. So you don't get second chances. You come in, you've got albuminuria, you've got diabetes, and you get an MI, you're dead. Or you just had a sudden cardiac death. The only way you can prevent it is to identify that risk ahead of time, because you won't be able to intervene, you won't get a second chance. Now, how do we know that this stuff works? Well, before 2001, we had very few tools available to us that could modify the cardiovascular risk in these patients. And the STENO2 trial that was done in Copenhagen with Dr. Hans-Henrik Parving, Dr. Mogensen, all those people who were involved, they took only 160 patients with type 2 diabetes. Not a huge number. We're taking 160 patients type 2 diabetes with moderately increased albuminuria. They received either conventional therapy or intensive multifactorial therapy. And the intensive multifactorial therapy included two parts. One was behavioral modification, diet, exercise, and smoking cessation, and the pharmacological modification, which included at that time ACE-ARBs, control of glycemia, and control of blood pressure that included thiazides and beta blockers. So very simple measures, and what they show is that in 1999, they published this in Lancet, reduced microvascular complications. In 2003, they published the same study in New England Journal. At 8 years, they have a cardiovascular benefit. In 2008, they show a mortality benefit, and even 21 years later, they showed that you could save 8 years of life if you took this treatment for 8 years. What is it telling you? For really a few rupees a day and behavioral modification, you can make a huge difference. You don't need to be someone with deep pockets. This is prevention. And what are they doing? Very simple measures, and they are producing very dramatic results. Well, fast forward 2022, Dr. Navnithan, who is at Baylor, he headed this group writing guideline about guideline adoption and patient selection for modifying cardiorenal risk. And this is a review of multiple guidelines. And when you have review of multiple guidelines, you need somebody to review the guidelines. And as Dr. Agarwal pointed out, I'm one of the editors for NDT, and I invited these two groups of authors, one from steno-diabetes, which is Peter Rossing and Frederick Person, and one from Washington University, Janet McGill and Ron Zhang. Janet McGill, incidentally, was in the renal trial. And I asked them to come up with the clinical implications and guidelines for CKD in type 2 diabetes. And they came up with a very nice summary. They says, all guidelines recommend annual screening for CKD, which includes albuminuria and EGFR, blood pressure control, and glycemic testing. They say RAS inhibition and SGLT2 inhibition are recommended by all guidelines. And Finerenone, the first non-steroidal MRA with renal outcome data, is recommended by the most recent guideline available. This is how they summarize the data. Well, we came up, Dr. Dennis Fook, who's the editor-in-chief, and I wrote an editorial. We called the foundation and the four pillars of treatment for cardiorenal protection in people with diabetes and chronic kidney disease. So remember, this is a foundation and a pillar. So what are the foundation? The first thing is cessation of tobacco smoking. You saw that it was even there in the steno group. So, he says, okay, cessation of tobacco smoking, that's pretty obvious. But, tobacco is not just smoking. It could be, the person could be chewing tobacco. In America, it says, do you smoke? No, I don't smoke. I vape. Oh, you are vaping. That's smoking. It's basically you're consuming tobacco. So it comes in various forms. And there's a big push that we ask for temperature, blood pressure, respiration, and heart rate. Take smoking as a vital sign, just like you do BMI as a vital sign, take smoking as a vital sign. Ask, advise, and refer behavioral counseling. But there are huge developments in pharmacotherapy. For example, nicotine replacement therapy, bupropion, sustained release, and varenicline. So these are specialists who do this, and you might want to refer people who are really interested in stopping smoking. Glycemic control, the level of which is individualized. Dr. Agarwal pointed out the advanced trial. Lowering blood pressure to at least 130 or 80 with attention to detail how it is measured. You can't just measure the blood pressure in your office. You have to have seated rest for 5 minutes, take it in triplicate. It's much harder than what you think it is going to take to get a good blood pressure. Management of dyslipidemia that is centered on the administration of statins, a healthy diet with a low glycemic index and restriction in sodium, and maintenance of a healthy weight and optimizing physical behaviors. So what do I mean by optimizing physical behaviors? Well, it's very interesting. They're very nice guidelines published in Diabetes Care last year. They say, you can do it very simply. When we think about exercise or optimizing physical behavior, we think about running on a treadmill on the road or things like that, but you can actually do better. First thing everybody else can do in this room is sleep. Sleep quantity and quality is important, right? If you're cutting short on sleep, it's going to affect your daytime physical activity. Now, during the day, your phone might actually beep at you. You haven't taken 100 steps this hour. So limiting the sitting amount. So you're moving around all day. Stepping, how much is that? I'll come to that in a moment. Stretching, which would include things like yoga and Tai Chi. And so far I've said, fairly simple things. Strengthening, which is things like weights or bands to avoid sarcopenia. And sweating is what we usually think of as moderate to vigorous physical activity, which is at least 3 times per week. But you can do the first 5, if not the 6th, to get there. And so how much stepping do we need to do? And this is a very nice collaborative in 2002. 47,000 adults, they looked at how many steps do you need to take to avoid death. And it says the answer is fairly simple and intuitive. It depends on your age. If you're Dr. Agarwal's age, 6,000 steps is good enough, right? If you're younger, that some people in this room, less than 60, you do 8,000 to 10,000 steps per day. So as you get older, you can do less stepping, but as you are younger, you can do a little bit more. What about the pillars? We talked about steno-2 trial, ACE inhibitor, angiotensin receptor blockers. And of course, we have this magic pill, SGLT2 inhibitors. Dr. Agarwal showed you the positive effects on the renal and cardiovascular outcomes, no question about that. And the great news is that in this country, the access to this medication is really unlimited. In America, where I practice, I have still to get prior authorization for these patients. In this country, for 5 rupees a pill, you can get dapagliflozin. EMPA is still expensive. It's still on patent, but dapagliflozin is pretty much in the drinking water here. Non-steroidal MRAs is what we're going to talk a little bit about, and GLP-1 RAs. That's the fourth emerging pillar because the renal data are a little soft on the GLP-1 RAs. Now, how do we get there? And this is important because, we have a large, complicated country like the rest of the world, and starts from clinical inertia or low awareness. That's what we are doing, tamsoma jyotirgamaya, right? If you're not aware, if there's darkness, you don't know albuminuria is important, never screen for it, you've missed an opportunity because you're waiting for failure to happen. And then it might become high drug prices or disparities in care. But I see that, as I walk into AIIMS, when I left AIIMS, there was nothing like poor patient help and things like that. That is coming around in this country. That's a huge opportunity that those disparities will shrink and everybody's health will rise. Right? Basically, the AIIMS motto was Sarve Santu Niramaya. Right? We want to raise the health of every person. Everybody's misery is the same. Whether you are a CEO or a rickshawala, it doesn't matter. You are entitled to the same level of health. Now, ACE inhibitors, ARBs, they are wonderful drugs, and they also didn't wipe out kidney disease. There was a lot of residual risk, and we did 2 trials, Credence, DAPA-CKD, and now EMPA-Kidney, which show that the residual risk continues to persist. What about SGLT2? And what Dr. McGill and Rossing and their colleagues summarize is that they are level 1A evidence, and they might be quibbling about EGFR thresholds or albuminuria levels, but most of them say they are organ protective, except the organ protection in people with diabetes without albuminuria or very little albuminuria is marginal. We don't have good evidence for that. But if you have cardiovascular disease, that means heart failure, then there's no question about it. What about inflammation and fibrosis? And we're going to next focus on this new kid on the block, the MR overactivation, as a way to target this inflammation and fibrosis. So, you have the mineralocorticoid receptor, and this is complicated because Dr. Narang, he was in biochemistry here, and he used to teach us that, look, a lot of receptors are surface receptors, but the steroidal receptors are intracytoplasmic receptors, and they have to bind, and they go into the nucleus and do their magic there. So they're complicated. And when you have MR overactivation, it does what a nuclear receptor does, complicated, and produces kidney damage, CKD progression, and cardiac damage. But it's not very simple. It's not just a surface receptor does its job, but it's complicated. Now, to understand a little bit of the complexity, let's look at an animal study, which is a head-to-head comparison of eplerenone, a steroidal MRA, versus finerenone. And the model is that the mouse is injected with a huge dose of isoproterenol, and it produces cardiac fibrosis. You can see in the left upper, right here, there's no fibrosis. That's vehicle. This is when you give finerenone, and this is when you give eplerenone. And when you look at the collagen content, the amount of pink is telling you the collagen content. The control is vehicle. This is vehicle and the isopropanol given, a lot of fibrosis. Eplerenone, some inhibition of fibrosis. When you give finerenone, there's a lot of inhibition of fibrosis. And also when you look at function, that is speckle tracking echo, they have better function, and they have also got less macrophage infiltration with finerenone. So what's it got to do with humans? Well, you can't do this study in humans. You can't do biopsies in humans and look at these things ethically. So you have to do it in animals to look at fibrosis and inflammation. But that's how you launch a program that leads to discovery of a drug. And I've been involved with this drug, say around 2013, 2014. So I've been involved with it for at least a decade. I helped design the ARTS-DN trial, and I was a co-author on that trial. So I've been associated with it for a long time. But the ARTS-DN, ARTS-HF, they were all phase 2 trials to get proof of concept. Is this drug working? And when we found that it was working, we did 2 large phase 3 trials, which was Fidelio and Figaro. The Fidelio trial was fairly simple. It took people with more advanced kidney disease, GFR between 25 and 75. And we looked at either getting placebo on top of standard of care, which included blood pressure control and ACE and ARBs in everyone. And the other group got finerenone in addition. And we looked at the outcome of progression of kidney disease. The Figaro DKD trial was looking at an earlier stage of kidney disease. These are the people who have microalbuminuria. These are the people who don't have much kidney failure. They didn't have an upper limit of GFR. They had a lower limit of 25, but upper limit was absent. And we looked at cardiovascular morbidity and mortality in these individuals. And what the primary endpoint was in Fidelio was the secondary endpoint in Figaro, and what the primary endpoint was in Figaro was the secondary endpoint in Fidelio. So they were complementary, but remember, they were also trials that were done in slightly different populations, Figaro being in an earlier stage and Fidelio being a later stage of kidney disease. But really the key question in these phase 2 trials is, does finerenone, a non-steroidal MRA, added to a maximized RAS inhibition, reduce cardiovascular disease and kidney disease progression over a broad range of CKD in people with type 2 diabetes? Okay. So who did we study? People with type 2 diabetes and CKD, eGFR more than 25, USCR anything between 30 and 5,000, which is a pretty broad range. And serum K had to be 4.8 or less at baseline. The reason is that we knew ahead of time that these non-steroidal MRAs can raise potassium. And if we started with 5.5, we would be stopping the drug the next day. We had to have some headroom to keep going in those individuals. And we excluded patients with symptomatic heart failure with reduced ejection fraction, because in those people, it would be unethical to deny them spironolactone. This says, okay, if you have HFrEF, we are not going there because it's unethical to deny. And we have large number of people, nearly 13,000 patients, 13,025 patients or so, who are randomized to either finerenone or placebo. Median follow-up is 3 years. 10 milligram finerenone is started if you have GFR less than 60, 20 milligram if you have more than 60, but everybody is targeted to getting to more than 20 milligram dose. The outcome is a CV composite, which is CV death, MI, stroke, or heart failure hospitalization. And we are looking at a 57% decline in kidney function, which is doubling of serum creatinine, or renal death, or going on dialysis or transplantation. They're relatively older individuals, 65 years of age is median, is typical, 30% women, RAS inhibition in everyone, statins in about 3/4, A1C is reasonably controlled, blood pressure is reasonable, 137 over 76, not the best blood pressure, but reasonable, and prior history of heart failure in about 7.7% of the people. Now, 40% of the patients in the Finerenone program had GFR more than 60. Those patients would never be recognized if you didn't measure injury, which is USCR. The median USCR was 515, and in fact, a third of the patients had microalbuminuria in this program. So here are the baseline characteristics of the patients. Notice that about 7% each were on GLP-1 RAs and SGLT2 inhibitors. And when we look at the CV composite, we find about a 14% relative risk reduction. The NNT is 46. The kidney composite is 23% reduction. NNT is 60. So this is not a mistake that I'm making. 14% relative risk reduction, you have an NNT of 46, and 23% NNT is 60. How did that happen? It's because of the absolute risk. The absolute risk is reduced more for cardiovascular than the kidney. And when you look at the kidney risk, it's important to note that both end-stage kidney disease and eGFR declines are blocked. Perhaps the most relevant endpoint for a patient who comes and sees you is going on dialysis, and that's reduced 20%. What about heart failure hospitalization? Cut by about 22%, CV death about 12%. And, again, to emphasize that 40% of the people would never be recognized if you just measured eGFR. So what do? We measure, and as probably consideration for finerenone use or any other diabetic drug, is measure USCR, measure eGFR. And finerenone measures serum K regularly to minimize risk of hyperkalemia. So you might be tempted to think, okay, I'm going to just use spironolactone or eplerenone. Well, it's a problem because remember, these are steroidal drugs. They are complex. Spironolactone in particular has a very long half-life, and it really never goes away after you dose the drug. It gets metabolized to 7-alpha thiamethyl spironolactone and candrenone, which hang out for sometimes weeks. Eplerenone doesn't have that kind of a half-life, but when you look at it head-to-head in animal studies and heart failure in human studies, there seem to be differences. Now, when you compare to historical controls, and it's a trial that I did, was an AMBER trial, which was looking at people with resistant hypertension who were given either spironolactone or patiromer with spironolactone. We found 23% of the people got hyperkalemic within 12 weeks, whereas hyperkalemia leading to drug discontinuation in FIDELITY only happened in 1.7% at a median of 3 years. Really apples and oranges. There's no question about hyperkalemia. Even if you look at when you match them and say, okay, let's take out people who have a GFR between 25 and 45 and match them for AMBER, you still have a huge difference in the incidence of hyperkalemia, 4.5% at 90 days versus 64%. And even with patiromer, you have 34%. So you can start the drug if your K is 5 or less. If your GFR is less than 60, start with 10. If you're more than 60, start with 20. But you want to get up to 20 milligram quickly, within a month, typically. When you call the patient back in a month, if the potassium is between 4.8 and 5.5, hold the dose. Basically, keep steady, keep giving the same dose. But if it's less than 4.8, you can titrate up. If you're more than 5.5, it's time to stop. Why? Because you've got a side effect that can be a problem. If you stop and potassium comes back, it might be something else that caused hyperkalemia, not finerenone. You can restart at a lower dose. If you have a recurrent hyperkalemia, then this drug may not be for you. But most of the time we can get by with this strategy. So here are the 5 facts I'll leave you. Start if k is less than 5. Keep going till k is at most 5.5. Use if GFR is more than 25, which is 5 times 5. Expect a fifth reduction in dialysis and more than a fifth reduction in heart failure hospitalization. You know, we used to have these books, used to read this Satoskar, and we had to make mnemonics and remember them for the exams, right? So I think this is a remnant of my All India Institute days that you said, okay, 5 for Finerenone, how do I remember? It was once I was giving a lecture, it says, you spoke too much, give me simple, I have a lot of things to do. I said, okay, I'll leave you 5 fingers of Finerenone. It says, oh, this is nice, I remember 5. So, okay, this is maybe a remnant of my All India Institute days. What about SGLT2 inhibitor use? When we look at the 7% of the people who are on SGLT2 inhibitor and people who are not on SGLT2 inhibitor, the effects seem very similar. How do I say the effects are similar? Because we look at the p-value for interaction and they are not significantly different. So we have similar effects in the 2 trials, but to prove this, we are doing a study called the confidence trial, where we are looking at reduction in UACR in people who get empagliflozin alone, or Finerenone alone, or the combination of the 2. It's a study that's ongoing, and we will have some answers in the future. What about the problems with this drug? Well, major one is nothing related to A1C or any sexual side effects, but potassium is an issue, change of 0.19, but a lot of people can stop this drug, about 1.7% versus 0.6. You might say 110 is a lot of people versus 38, but that's a 13,000 patient trial. So you'll have to write 71 prescriptions before you have one patient who's stopping the drug. Now we have, talked about this information that if you have type 2 diabetes and leukoprotein in the urine, you're going to die. You're going to have cardiovascular death. Says, well, the patient doesn't really want to hear that. Says, doc, can you do something about it? Is it modifiable? And yes, it is. Look at placebo versus Finerenone in people with GFR less than 60. People with more than 60, again, a reduction in risk. If you have USCR less than 300, reduction in risk. USCR more than 300, reduction in risk. Everything reduces. Now, what we learn is that CKD is a modifiable cardiovascular disease risk factor. After 1 year of Finerenone treatment, it's estimated that 2/3 of the population cardiovascular benefit will be observed in people with GFR more than 60. These are people who will only be detected if you measured USCR, and 3/4 will be observed in people with microalbuminuria. So it's really important to screen and treat early, because that's where you can make a huge difference. What about GLP-1RAs? Well, this is what Dr. McGill, Rossing, and the co-authors said. In summary, GLP-1RAs are an important adjunctive therapy for patients type 2 diabetes and CKD in all guidelines, though dedicated renal outcome trials have not been completed. Trials like FLOW and SOUL, in a few years you'll have information. So how do we integrate these guidelines to optimize cardiorenal outcomes in type 2 diabetes? Well, first we have to recognize that glycemic control is not enough, that we need to identify CKD early, because it's not just a kidney risk factor, it's a cardiovascular risk factor. If we make it universal, then it's no longer an academic exercise, because we talked about so many things we can do sitting here in the room with no money, which can modify your lifestyle, your risk, and simple measures like cessation of tobacco smoking and blood pressure control, glycemic lipid management, they can all make a difference. The cardiovascular pillars are 4, I'm not going to repeat them. And who should implement the guideline? I think that everybody who's listening to the talk has the responsibility for implementing this, because I would say that a third of the people who are there in the room, they probably have diabetes, or they have a family member who has diabetes. If they have it, you ask them, did you measure your USCR this year? If not, let's do it. Thank you for your attention. Any questions? Be happy to take.
Rajiv, these trials are very well, I will say, is very well monitored trial.
Yes.
There is a cutoff of the potassium of 4.8 before the patient is included. But
Right.
in a real life situation, particularly patients who are already on ARB,
Yes.
their potassium is usually on the upper side.
Right.
And very few will be having less than 4.8.
Right.
And if you compare the trial published of spironolactone in 1990, study shows much less hyperkalemia incidence. But in real practice, after the drug was approved for
Yes.
that, not many patients started getting admitted with hyperkalemia.
Right.
In a real life situation, what is your
Right.
assessment
Very good question.
in
So,
terms of a utility?
yes, Dr. Agarwal asks a very good question, because what he's pointing out is that, you're doing a trial which is in a controlled situation. People have a potassium of less than 4.8 and you're recruiting them. And what happens in a real life? So, first of all, there were 2 times that we measured potassium. It was baseline and screening. And after the screening, there could be up to 2 weeks that could elapse till the time of randomization, that the patient could have a change in potassium, and you couldn't do anything about it. It turns out about 700 patients had a potassium of more than 4.8 at time of randomization. And that's why the FDA has in the label that you can go up to 5 to randomize. The study that you point out is 1999, Bert Pitt, which was Bertram Pitt was the not the actor, but Dr. Pitt, who published the RALS trial. And it was a seminal trial which looked at people with heart failure with reduced ejection fraction. It showed a mortality benefit, and that trial was actually completed early because of the DSMB said you can't go further because you have a mortality benefit in this. After that trial was published, they had this Canadian study, which was by Jurlink, and he looked at the Toronto database and said, a lot of people are getting admitted with hyperkalemia. There's a problem here. It turns out that there was an editorial that was written at that time by John McMurray on that same paper. He says, the reason is that the people started using the drug with irrational exuberance. They had a GFR less than 60, recruit. They said maximum dose in RALS trial 25 milligram. They said we'll use higher dose, 50. You start using things which are outside the label, you get higher. The question that you had was asked by the Canadian health authorities to Bayer before they would approve the drug, because it was Canada. Jurlink was doing the study. So Bayer produced the real world data and gave it to them. It says, what we have monitored so far, we haven't found anything. I can tell you from my personal experience where I have used spironolactone in clinical trial setting and finerenone in clinical setting, which clinical trial setting is much more monitored. Clinical setting, whatever happens. It's very rare to get people hyperkalemic with finerenone, very common with spironolactone. I was the first author on that Lancet paper with AMBER trial. 2/3 of the people get hyperkalemic within 12 weeks if you're using spironolactone. And even if you use spateromor, 1 out of 3 people got hyperkalemic. So I think spironolactone and this drug's fundamentally different, as something to do with the half-life, because finerenone half-life is just 2 hours. It says, oh, you have a drug with a half-life of 2 hours. How do you get any benefit with this drug? You take it, it goes away. Well, the clinical trial proves that it has a benefit, right? You don't need to worry about how it produces benefit. It doesn't produce so much hyperkalemia, but you still get benefit. But that might be the secret sauce of the drug. The drug goes blocks the receptor for a short period of time, leaves it unoccupied so you can get rid of K, but it's still doing its magic on inflammation and fibrosis behind the scenes to get the outcomes down. So fundamentally, very different drugs. But that question was asked by the Canadian authorities when they looked at the data. They approved the drug in Canada also. So in India, when you're using the drug, you have to be careful because a lot of potassium is not measured here. People don't like to pay for tests. They said, Doc, I'll pay for your medicine, but testing, don't ask me to pay for it. That's useless. But if you're using it, I think that especially when the patient gets sick, you come out with diarrhea, hypotension, or you're in the hospital with something, hey, measure potassium, that's when things can go wrong. Or when you have started eating too many watermelons, you have a lot of potassium rich foods, then you have a problem. Or you're in Nagpur, you are having a lot of oranges, so orange juice, you have a problem. So, you have certain situations you have to be careful, but most of the times you will find benefit with this drug.
Side question, if the half-life is 2 hours, but still it is once in a day.
Yes, it's still once in a day. So this was the very interesting thing. So we did 24-hour ambulatory blood pressure monitoring. So a drug, 2 hours, it should have no effect after 5, 6, 8 hours. You look at the 24-hour blood pressure profile, it's consistently drawn down after about 3 weeks. So what it's telling you is the pharmacodynamic of this drug. It might have a half-life of the pharmacokinetic, half-life is 2 hours. But what it's doing to the pharmacodynamics at the nuclear level is a much longer half-life. So that's affecting all the measures that are of benefit to us. But because it's short half-life, perhaps the potassium is not being affected as much. That's my rationalizing of the data. We of course don't know because we don't measure DNA products or anything like that in humans, but they are fundamentally different. But even when you look at 24-hour blood pressure monitoring, and we have published this in Journal of Hypertension recently, looked at resistant hypertension and the use of Finerenone in those patients, and we found that it actually has a 24-hour blood pressure control. Quite remarkable. In the ARTS-DN trial, it had about 10 millimeter drop in systolic blood pressure with 10 to 20 milligram dose.
Any other question?
Yes, please. 2 more side effects. Very good question. 2 more side effects, which are there in the label. One is hyponatremia, happens very rarely. And third, you probably need to remember is hypotension. Because I told you, okay, it drops the blood pressure 10 millimeters. What if somebody has diarrhea or gastroenteritis? They're taking Finerenone. And, the patient comes to you, doc, you give me this medicine, बहुत चक्कर आते हैं. He says, नहीं, ये medicine के लिए की side effect नहीं. But it could be because it is a drug that drops blood pressure. Both of them are in the package insert. Doesn't happen very commonly, but these patients are also on diuretics, ACE inhibitors. So we just have to be mindful that the patient is probably telling you something to be careful about. So hyperkalemia, hypotension, hyponatremia, that's it. Those are the 3 major side effects.
We are adding this drug mostly at a GFR of less than 25, more than 25.
More than 20.
So have you tried it at a lower GFR because that's when the patient gets more sensitized to have the nephrologist to add more drugs?
Yes, very good question. So question is that what would you do? So let me answer your question 2 ways. Say your patient, you started at 30. Now patient's GFR is 20 or 15. Will you stop the drug? No, you keep going. The same thing is true for SGLT2 inhibitor. The same thing is true for Finerenone. You don't stop the drug till the patient gets on dialysis because it's going to continue to work. What about people with less than 25? Is it going to work? That's a judgment call that you have. I cannot tell you by the label that you should, because we have not studied them. But as physicians, we are often asked to work in data-free zone. So you're going to use all the wisdom that you have and ask yourself, if I were the patient, would I take the drug? If the answer is yes, you might consider that in that individual. In the place I practice, the answer is no, because if I write for it, the pharmacy will automatically say GFR is 24.8, patient not eligible. Pharmacist decides. I don't. Okay. But place you practice, you can decide, but use your best judgment to see if the patient can potentially benefit, because we don't have much data in that population.
There's no criteria like 30% fall in GFR.
Well, if you have an acute decline in GFR, you might consider factors. But when we looked at the entire Fidelity database and we asked the question, how many patients had more than 30% decline in GFR within a few weeks of starting the drug? Maybe a handful of patients. It doesn't happen very often.
Less than SGLT2.
I cannot say that with confidence because we haven't done a head-to-head trial, but the confidence trial will answer that question because we are randomizing people, right, to either an SGLT2 or Finerenone, and they're coming back in 4 weeks. So you will be able to see how many people have an acute decline in GFR in one of the two groups. More important, how many people have that decline when you start the two drugs simultaneously. And this is all over a background of an ASOR. So that is the proper study to do. But we don't really have much data to support that right now. Yes, yes, yes.
Specific deadline where we stop the drug. Supposedly a patient is already on Finerenone and the GFR is reduced below 25. You said that we still have to continue the drug. Is it a specific
No, you will stop the drug if the patient gets on dialysis. And the patient might not get on dialysis till the GFR is 5, right? So you keep going. Or you find, oh, the patient got hyperkalemic, more than 5.5, I cannot really continue to prescribe you this drug. That's when you stop. But there's no GFR threshold that says, okay, you have reached too low a GFR, I must stop the drug. You stop the drug when the patient is on dialysis. Why? Because you know that the drug is reducing the need for dialysis. If you know that, if you stop the drug before the patient gets on dialysis, how will you get the benefit? Right? If the patient is not taking the drug, you won't get the benefit.
Nothing in the chat. Where do you see this in the treatment algorithm? Will it be higher than SGLT2? Probably the confidence.
Well, where do you add the drug? I think it's clinical judgment many times. Okay, I'll give you some scenarios. I just had a patient who had a urinary catheter, right? He's got dirty urine all the time, is on an ACE or ARB, right? Patient, I'm not going to start the patient on an SGLT2 inhibitor. I'm just playing with fire. I'll start an SGLT2 inhibitor. Can I start on an SGLT2 inhibitor? I cannot, because the requirement of my healthcare system is such. But in a clinical judgment where you are practicing, where you are free to prescribe what you want to prescribe, that would be a patient where you would say, oh, I think I want to prescribe this. In a patient who has, say, potassium of 5.1, I would prefer an SGLT2 inhibitor, right? Because this drug won't be used. It says, okay, let me prescribe you an SGLT2 inhibitor, and say the K is now 4.8. Then you add this drug, you are on much safer ground. Why? Because we know from post hoc studies that when you use SGLT2 inhibitor in combination with Finerenone, the risk of hyperkalemia is lower. So that would be a situation that you would go towards SGLT2 inhibitor. If I'm practicing in India, I would find a good reason not to use a SGLT2 inhibitor before I dismiss it. I think it should be, in most patients, it should be the standard of care, because this is whether you have diabetes or no diabetes, that's where you use. Finerenone is not yet indicated in people with non-diabetic kidney disease. You can use it off-label, but FIND-CKD is the trial that is being done in non-diabetic kidney disease to see if it works. But we have good data in people with CKD and non-diabetic kidney disease that this drug works in proteinuric kidney disease, not vasculitis, not PKD, but other kinds of diseases. So I think you have to just use your clinical judgment, and you are in an amazing place that you don't have the restrictions of other people telling you how to practice medicine. There's nothing coming between you and your patient to practice.
This has always been used as an addition to standard of care, where we leave AC or ARBs as standard of care. Is there a possibility that this would compete with ASARBs as the first two?
Very good question. Yes. So the question you are asking is a very important one. Should standards of care change as new drugs come along, right? Remember, in cardiology, streptokinase used to be the standard of care. You would never hear about streptokinase because it went away, Then came TPA. You never hear about TPA because everybody gets primary angioplasty these days, right? Standard of cares evolve and change. And I think that there will be a time where we will come and challenge the standard of care as ACE and ARBs. Because what if the ACE and ARBs are doing nothing when you add it on top of finerenone? In other words, if you remove ACE and ARBs from finerenone, do you get less hyperkalemia with as much benefit as continuing them? That study has never been done. Great question. I've advocated for it, but it's a high-risk study. So it'll be a fascinating study to answer the question that you're posing. Is the standard of care really ACE or ARB if you have a more downstream inhibition of the renin-angiotensin system that is now producing very little hyperkalemia? And says, I don't know, but we need to challenge it in the future, because that's the motto of Tamsoma Jyotirgamaya. We have darkness, and because we want to Sarve Santu Niramaya, we can't keep people healthy if we are living in darkness.
Another is very similar. Many patients doesn't tolerate most of the time maximum tolerable dose of ACRB. But many patients doesn't tolerate in spite of having reasonably preserved GFR, particularly diabetic patients. We cannot use ACRB. Do you think that using finerenone will be equally risky in terms of producing hyperkalemia, or it may not be necessary?
Great question. So
we still use finerenone,
right,
in spite of ACRB not being used because of it.
Right. So the question is very simple. Dr. Agarwal is asking, many people can't tolerate ACE or ARBs. I have now the option of finerenone. Will you use this drug, or just say, oh, they didn't tolerate ACE or ARBs, they won't tolerate this? When I was practicing, when I was learning, I was a student here. There used to be a term called diagnosis ex juvantibus, and it was used for diagnosis and treatment. It was used for tuberculosis and typhoid. Right? If you used anti-tubercular therapy for 3 weeks and the fever went away, it must have been TB. If you gave chloramphenicol and the fever broke, it must have been typhoid. Diagnosis ex juvantibus. What I'm getting to is that use the drug, call the patient back, and see how it works. Because there is no substitute for trying out individual level. For each of the 8 billion people on the planet, everyone is unique. They're going to have a unique response to it. And just to say that, 1.7% of the people had it, So you could be at 1.7%. You don't want to be that statistic. So you want to observe. But I absolutely would use that in that individual and be vigilant that, hey, I just want to call you back in 4 weeks. Make sure that your potassium is good and your GFR is still good and you're tolerating the drug. And if it is, then we might have discovered something which is useful for you when other therapies that were standard of care might not have worked. That's the way I would approach it.
That is obviously very clear that you can't predict that.
Predict, right.
But you see, in many situations, we are not expecting, or in a real ground level, patient will not come back for follow-up as frequently as we wish.
Right.
So if we have got hyperkalemia with ASARP,
Right.
in that situation, we are not sure the follow-up
Yeah,
will be.
so, I don't think that I would, the way I would look at it, hyperkalemia is a nuisance. Dialysis and heart failure is a real problem. I would rather address a real problem than not be bothered by the nuisance. Sometimes we look at the side effects, and understandably so, because we have always been taught first do no harm. It says, but if you are always going to stick to that first do no harm, are you denying the benefit to somebody? That's a judgment call, and that's something that only you can make at the bedside. But that's the approach that I would take and say, okay, you're not going to see me. Your potassium is 3.8. The average rise is 0.19. I don't think you're going to get hyperkalemic. I'm going to risk it. I'm going to prescribe it to you. I would use some fine tune.
There are some questions online.
Yes.
All regarding potassium.
Right.
Can potassium binders be used along with finerenone?
Sure, you can use it. It'll be, you don't want to, my rule of thumb is you don't want to use multiple therapies to enable another therapy. If you really want to enable the use of finerenone, perhaps you want to reduce the dose of ACE or ARB and place them on a diuretic, but that's completely off-label. That's a judgment call again. What if the patient is hypotensive? You don't want to use a diuretic. What if the patient has a potassium of 5.5? You're supposed to be stopping the drug because that's what we did in the clinical trial. The use of binders was more in people who got finerenone, but they were transient uses. They were not persistent uses for months. So it wasn't enablement of the use of the drug, but the transient use to overcome hyperkalemia.
Any specific reason that it was indicated with diabetic patients only, data on other non-diabetic CKD patients?
Very good question. The question is that why don't you have data in people without diabetes? And it's just the strategy because, the drug approval business is complicated. It's not just science, right? You have to go through regulators. And say you said any kidney disease, diabetic or non-diabetic, you'll have to do a very, very large trial when you don't even know that's going to work in a certain subgroup of people. So the strategy they took says we're going to study it in diabetes, then says, okay, now we're going to study in people without diabetes. So the FIND CKD is in people without diabetes. They're going to launch a trial in type 1 diabetes. It's called FIND-1. They have a trial called FIND-ARTS, which is in people with heart failure with preserved ejection fraction, and that's in people with diabetes and without diabetes. So you first get the drug approved, and then you expand the role of it. That's a strategy rather than a scientific approach, because there's limited amount of resource and risk taking. It's very expensive to do these trials, 13,000 patients, global, more than 1,000 sites, 70 odd countries participating in it. Very expensive to do it. And when you look at the regulatory approval, if the drug doesn't get approved and you expanded your reach to all these population, then you are likely to lose much more.
Most of these trials, I'm member of drug regulatory.
In India,
So
right?
most of the time they choose initially to start with subset where there is likely to be benefit
Correct.
and where there is a least risk. Also.
Correct. Right. And I
As
think
you said,
that then you
expand.
expand. And I think that's reasonable because, you know, that's say even when you have patients, you says which patients will you treat first. It says the ones that you are more certain that they're going to respond. Once you get confidence with the drug, it says, okay, let's expand it. I think that's the approach they take. But here it's a commercial consideration too and a regulatory consideration too, I think.
So you mentioned that you've been involved in the development of the drug the last decade or so. So I just wanted you to go back in time and answer as to what made you study this drug in the first place. So I think you were involved in the animal studies as well. So I'm not sure about that.
Yeah.
What made you study this?
Well, I think honest answer is I was invited to participate because I had an interest in hypertension and that's what they were investigating and kidney disease. So I was asked to be a part of this committee of 6 people. There were 3 nephrologists and 3 cardiologists who were overseeing this trial. And I was asked to be part of it. It wasn't like I was telling them what to do, but I was telling them, giving them the advice on how to approach it. You know, to go back in time, you know, we had 2 trials. That one was the VA Nephron D study. That was looking at combination of losartan and lisinopril versus losartan alone. It was a combination therapy, and it says, okay, more RAS inhibition should be good for you rather than less. The other one was called the Altitude study. It was looking at aliskiren with valsartan versus aliskiren alone. Again, looking at the same thing. More must be good. Both the trials were terminated early. The aliskiren trial because of futility and also increased risk of acute kidney injury and hyperkalemia. The VA Nephron D study was terminated early because of acute kidney injury and hyperkalemia. We were doing the Fidelio and Figaro at that time. Again, the concept is the same, a combination therapy. There were 2 other companies that were doing trials at that time. One was Pfizer and the other one was Eli Lilly. They both had non-steroidal MRAs. And they said, we're not going to do it further. We are folding shop. They walked out. So Bayer was the only one that continued to do it. People were laughing at Bayer. He says, can't they see the writing on the wall? Combination RAS therapy doesn't work. And as they say, it's important to get lucky than be intellectually right. And we just got lucky. Because when the trial results were announced, I says, oh, we have a huge effect. If you ask me that question, blood pressure 137, 72% on statins, everybody on RAS inhibitor, average hemoglobin A1C 7.7%, median UACR 515. Will you think that Finerenone is going to work on top of RAS inhibitor after you have known that the VA Nephron D and aliskiren have failed? I said, oh my goodness, that's a tough call. And I think, yeah, these guys they're taking a huge risk. Now, you know, you look at it, says, yeah, we found an effect, but we got lucky. And I think we got lucky because the science behind Finerenone was really something that is untold. I visited the place where this drug was invented. It's a small village like Kurukshetra or something. You know, Kurukshetra is not a village, but this is a village outside Frankfurt called Wuppertal. Wuppertal, when you go there, just fields out there. And there's this one building that they do research. And this guy who led the invention team, his name was Peter Kolkoff. Peter Kolkoff and I are about the same age. And I asked him, hey, Peter, can you teach me about this drug that you discovered? He says, yeah, I will come to Frankfurt. I will meet you there. I says, no, I want to learn. I'm coming to you. I say, okay. I took a train to Wuppertal, middle of nowhere. And I went there. I realized this guy studied spironolactone since the 1950s, how it was discovered. And he screened 1 million compounds in the library of Bayer to find one that blocked the receptor, the steroidal receptor, but it was non-steroidal. And guess what? It was a dihydropyridine like amlodipine. And then he had amazing chemists who modified and tweaked this molecule. And they made sure it wouldn't have off-target effects. You don't see any Stevens-Johnson syndrome. You don't see any liver toxicity. Why? Because they tweaked the molecule to such a degree that it wouldn't produce those side effects. And they did it using small molecule engineering there. So they are chemical engineers, and Peter Kolkoff is a molecular biologist. He's doing the high throughput screening. And then they use the traditional tools of Kanagawa was a Japanese guy who actually measured urine sodium to potassium ratio after giving spironolactone to understand whether it has an MRA effect. He used the same in these rat cages, gave them Finerenone to see if it's working. I saw those cages there in his lab. It was a room half the size where he has these cages. He discovered this is a drug. And then the Bayer leadership invested in him when they had competing priorities, and they took a risk. When you define success, it's very complicated. It's not just Peter Kolkoff or not just the company. It's not just the chemists, but all the stars got aligned and humanity was gifted with a gift. And look at it. I mean, you have a drug now. 10 years from now, it'll be off patent. You'll be using it like statins. It's going to save countless lives because, you know, the people who can't afford it will be able to afford, just like dapagliflozin. It's 5 rupees a pill now. It's going to get there. But the impact on lives of people that these drugs have are truly the conglomeration of the intelligence of all these people, the Peter Kolkoff, Barfacker, who is the chemist, their teams, and coming around and making this magic happen. I mean, it's truly a remarkable journey if you look at it. How he discovered the molecule and how he made it is truly remarkable. But that's what I learned, is that when you discover something and you are gifted with something which is truly extraordinary, then look at the blessings for the patient, you know, which is sarve santu niramaya, because you have had tamsoma jyotirgamaya. Your darkness has been dispelled, but now your duty is to improve the pain and suffering of the people, because if you don't prescribe the drug, what are you doing? You're putting them at risk. But if you're not prescribing because of fear of hyperkalemia, what are you doing? You're protecting yourself, not the patient, right? So there's a dual commitment here. But that's all I have to say.
Yeah, no, it's a wonderful talk.
Thank you.
Much more trying to explain queries raised in the minds of the people.
Thank you. Thank you for coming.
That we will end this.